Hello everyone, I am Dr. Anil Kumar, Assistant Professor in Department of Anesthesia and Critical Care. I will be discussing the topic antimicrobial stewardship, which is of very high clinical relevance in the current context of antimicrobial resistance. All antibiotics are unique. When a physician prescribes an antibiotic, he could actually initiate a process that makes antibiotic ineffective globally. There is a serious threat by the World Health Organization, which has been seeing a lot of antibiotic resistance bacteria, and they have been classified as priority 1, priority 2 and priority 3 based on the priority 1 organisms are like Acinetobacter, Pseudomonas and Enterobacteriaceae. Priority 2 are high, that includes Enterococcus faecium, Staphylococcus aureus, H. pylori, Campylobacter, Salmonella. And similarly, you have priority 3, which includes Streptococcus pneumonia, Haemophilus influenza and Shigella. There is a significant antimicrobial resistance which is prevalent in our own country. There is a lot of superbugs, there is a lot of antimicrobial resistance in our own country with the over or excessive or overzealous use of antibiotics in our country. There is a lot of drug resistance which is a global concern as per the ICMR, as per the WHO. There is a significant threat about the ongoing antimicrobial resistance across the globe and even in India. If you look at the development of antibiotics, there are not significant antibiotics which are developed over in the last 5-10 years. So that even the older antibiotics are being reutilized for some specific purposes and they are found to be effective. So based on that, we don't have too much of newer antibiotics to fight with the antimicrobial resistance. The causes of antimicrobial resistance could include overprescribing of antibiotics, patients not finishing their treatment, overuse of antibiotics in the livestock and fish farming, poor infection control practices in hospitals and clinics, lack of hygiene and poor sanitation, and lack of new antibiotics being developed. There are a lot of organizations, those who are working to develop this or tackle the antimicrobial resistance like IDSA, ICMR, WHO, CDC. All are trying their level best to incorporate education to develop antimicrobial stewardship practices and to avoid overzealous or excessive use of antibiotics. We need to balance the antimicrobial therapy so that you have an appropriate initial antibiotic, and we need to cut short the unnecessary antibiotics. That is called a balancing act or an antimicrobial stewardship program. Why stewardship is needed? Up to 50% antimicrobial prescribes are inappropriate, and there has been a causal relationship between the antimicrobial use and emergence of resistance. So what is antimicrobial stewardship? The optimal selection, doses, duration of antimicrobial treatment that results in the best clinical outcome, or treatment and prevention of infection with minimal toxicity to the patient and minimal impact on the subsequent resistance. In short, we are looking at the antimicrobial stewardship practices where we decide a better selection of an antibiotic, appropriate doses, appropriate duration to have the best clinical outcome in terms of treatment, prevention and minimal toxicity, and so that we tackle the antimicrobial resistance as well. There are 3 goals of antimicrobial stewardship. First goal is each patient receives the most appropriate antimicrobial. The second goal is to prevent antimicrobial overuse, misuse and abuse. And third goal is to minimize the development of resistance. There could be secondary goal which could include reducing the healthcare costs without adversely impacting the quality of care. The goals of antimicrobial stewardship we need to discuss in detail. Each patient receives the most appropriate antimicrobial in the form of 4 Ds. We call it as right drug, right dose, right duration. The second goal is to prevent overuse, misuse and abuse. So there are a lot of antibiotics which are being prescribed for viral infections, for non-infectious causes, or a patient being bacterial infection being prescribed viral illness, or mild illness or colonization is being over-treated. So those are the areas where we need to have an antimicrobial stewardship in place. A lot of patients are on broad spectrum. They can be doing well on a mild or a moderate kind of antibiotic support. All patients does not require polypharmacy or combination antimicrobial at the first go unless they are going through the phase of severity of illness or in terms of worsening in the clinical situation. Third goal is to minimize the development of resistance. Antimicrobial resistance is associated with increased morbidity as well as mortality. So if you look at an antimicrobial or an antimicrobial stewardship team, it should have an infectious disease specialist, it should have an infection control nurse, it should have a microbiologist, intensivist, nursing team, clinical pharmacist, surgical infection expert, OT personnel, administration. They all form a big team which deals with this problem of antimicrobial stewardship or the antimicrobial resistance. The antimicrobial stewardship has got 4 strategies. First strategy is supplemental antimicrobial stewardship. Strategies will include education by sharing a good clinical guideline, good infection control practices. We can utilize antimicrobial order forms, switching as quickly as possible from IV to oral route, dose optimization via PK/PD characteristics. And there is some role of antimicrobial cycling, which is not a very too much of clinical relevance in the present context of antimicrobial resistance. Education studies programs requires an active interventions, guideline, algorithm dissemination across the treatment or the clinical groups, guidelines and clinical pathway, your own antibiogram related policies, and continuous feedback with the practitioners will help. Antimicrobial order forms also facilitate planning, practice, audit and feedback so that we improve on your antibiotic practices. Day 3 review bundle, quickly de-escalation of antibiotic based on the clinical condition requirement of the patient. So we can revise our antibiotic plan on day 3 or day 5 of critical illness, where we start with poly or a combination of antibiotics, and there we can de-escalate based on our culture or the diagnostic workup or the culture characteristics so that we can de-escalate our antibiotics. IV to oral as quickly as possible, dose optimization via PK/PD characteristic, as most of our septic patients or patients in severe sepsis, they have a lot of organ impairment as a part of sepsis. So these patients do require modification in the antibiotic doses to avoid the further side effects or the deleterious effect of antibiotics in a impaired organ function. Similarly, you have barriers, a lot of barriers to implement antibiotic stewardship program. One could be lack of understanding of the problems. Who cares? Staff may not assume it is an added responsibility. Always a clinician feel my patient is too sick, better to add a combination of antibiotic therapy. Do add an antiviral so that you expect a better outcome. You should not miss any fungal, bacterial, viral. So there is a lot of polypharmacy, which is a major barrier towards our antibiotic stewardship program. If you want to look at, we can still do much without a big problem. Every ounce of stewardship counts. So we have to start thinking big, and all clinicians, all nurses, a clinician should be more wise in terms of choosing the antibiotic plan, in terms of following your own hospital antibiogram, following your own clinical guidelines, following a spectrum of problem which requires subset of problems. Where we require a mild antibiotics, there are subset of clinical issues where we require a poly combination or a combination of antimicrobial drugs. There is few subset of patients, those who require fungal therapy as well, few subset requires antiviral. But every patient does not require all antifungal, antiviral or this combination of antimicrobials. Good infection control practices holds a lot of value in terms of reducing the antimicrobial resistance, in terms of patients doing well, in terms of reducing the morbidity as well as the mortality. Hand hygiene is the most effective tool. There are restricted antibiotic forms to utilize your antibiotics in an appropriate manner. A lot of restricted antibiotic needs approval with the treating clinician as well as with the infection control team. And a lot of diagnostic or the early diagnostic tool or the point of care diagnostics are also helping in a big way to reduce this or a better implementation of antibiotic stewardship program. So in short, if you look at antimicrobial stewardship is very essential component in day-to-day clinical practice of intensive care. And the way we are seeing a lot of antimicrobial resistance in the present context is going to add more and more morbidity and mortality to the patients in intensive care. it does add to the cost of care. It increases the length of stay, it increases the cost of treatment as well as the morbidity and mortality. So if you want to reduce the burden, I think this is the time where we need to follow guidelines, we need to develop your own antimicrobial stewardship team in your respective hospitals and follow the guidelines which are based on your local antibiogram and based on your hospital infection control team along with the infectious diseases consultant. We have to use antibiotics judiciously. We need to quickly think of de-escalation of antibiotics. Quickly we need to think of IV to oral. So this is how we must develop and learn the antimicrobial stewardship skills. Thank you.